Oh, good afternoon, everyone. The pregnant pause there was just waiting. There's about 300 other people online. We're just waiting for them to join us today. So thanks so much for taking the time to have such a beautiful day to be here to join us today to talk about controlling and hopefully conquering CLL. So I'm John Gribben from Barts in London. I'm actually, this afternoon, I feel like an honorary Billy Joel of this New York state of mind with John, Allan, Nicole, and Megan, all from various institutions in New York City. I would like to thank Peerview, Penn State College, and the CLL Society for providing this session, as well as the sponsors, AbbVie, AZ, Lilly, Pharmacyclics, and Janssen for providing educational grants for this symposium. If you haven't done so already, we'd ask you please to complete the pre-event survey, and I'll, at the end, remind you to please do the same about your evaluation. We'd like to know what you liked, equally as much what you didn't like about this afternoon, so that when we plan sessions for the future, we can make it more about your needs than for our own. Reminder, look out, use the iPads that you have there, look out for additional follow-up polling during the presentations. And we're not going to take questions from the audience during each of the individual presentations, but there's plenty of time at the end where we're looking forward to getting your questions up there, and we'll get through just as many of them as we can in the time that we've got for the discussion. I'm going to be a whip out to make sure that they go on time to make sure we've got plenty of that time for you. So you can visit us at peerview.com/2023-CLL to view the slides and the practice aids now, and you can download them after the event. For more information, you can use the email address that's there. And to join the conversation, those of you who are still not turned off by the owner can now still use X, formerly Twitter, at Peerview.
I forgot my glasses.
We're talking this afternoon about targeted therapies, and as we're just talking among ourselves here today, I can't remember the last time I used chemotherapy for a patient with CLL, which is a great place to be. And of course, we've now got the approved agents, ibrutinib, acalabrutinib, and zanubrutinib as the BTK covalent inhibitors. They're all approved. We've got the emergence of the BTK non-covalent inhibitors, pirtobrutinib, now just licensed in the US for mantle cell lymphoma. We've got phase 3 study data leading us to believe we're going to have this agent available to us for CLL very soon. Nantabrutinib is the other BTK inhibitor, which is also in late phase development, and you'll see the Bellwave 8 study being updated at this meeting here. Despite all these advances, and despite the fact that we're talking about how we don't use chemotherapy anymore, we're still seeing there's a lot of work that needs to be done. And just draw your attention to this presentation, which will be at this meeting here. A large database, more than 6,000 patients, following what's happened to the treatment of patients in the last 4 years. And what you'll see is that although there's a good penetration into the marketplace of these agents, there's still about 20% of patients still receiving chemotherapy, and that 20% doesn't really appear to be changing all that much over the last few years. So still plenty of work left to do. We also know, of course, that the real-world data that's out there shows us that we need more newer agents and new ways of looking at how we plan to use these agents together. And for that group of patients who become both either intolerant or resistant to both BTK inhibitors and BCL2 inhibitors, their current outcome still looks very poor. And that's something that clearly many of us are working on very hard at the moment. So our goals today are, for those of you who don't already know it very well, in which case, like Michael Griever, who's sitting over there somewhere for some reason, and say that, Michael, why are you here? You know all this already, but good to see you. We want to improve your understanding of evidence supporting these modern targeted platforms as both upfront and sequential therapies, to equip you with the skills you need to select which is the best personalized BTK inhibitor or BCL2 inhibitor platform to manage your patients, whether they're treatment naive, or when you're looking to choose what's the one you're going to use first with what's the one you're going to use second. We want to provide you with guidance on the safety, dosing, and other practical considerations with practical therapy and other innovative options in CLL. Particularly like to thank our partners. I feel very noble on the Ash Friday, when everyone else is off making money for pharmaceutical companies, that we are here doing our bit for the CLL Society. So I think you saw the video at the beginning, and I think they do, and other patient organizations, an amazing job in helping provide our patients. What I'd like to have you lead into now is a short video from Larry Marion, who's going to talk about his journey with CLL. So if we can have the video from Larry, thanks.
My name is Larry Marion. I am now 73 years old. I was diagnosed in 2005 when I was 55 years old. I was diagnosed by accident during an annual physical, which is very typical for CLL diagnoses. When I was diagnosed, I not only was diagnosed with CLL, but I had a bunch of bad markers. So I was 55 years old, had a daughter just entering high school, and was told that basically I had 5 to 6 to 10 years if I was lucky. Then I had a problem. BR wasn't working, I still had a lump in my throat, and what to do? At that time, it was becoming clear that ibrutinib was going to be approved very quickly. And there was great, the clinical trials, the data was showing great results for ibrutinib. So I decided to stop the BR and gamble that ibrutinib would solve my problems. Fortunately, I gambled correct. One of my hemocs said, why don't we just switch you to venetoclax, which had been approved at that point. And so I stopped the ibrutinib, went on venetoclax. 16 months later, undetectable MRD, happy camper. And that was where I stood for almost 3 years. I had almost 3 years of undetectable MRD. So I'm very grateful at this point. I am essentially 8 years beyond my expiration date. It sounds sort of funny for people with a terminal cancer diagnosis, but we're in a golden age. CLL patients have never had these kind of options before, and the kind of efficacy we're seeing with with these new drugs. Beginning 10 years ago with the approval of ibrutinib, followed by acalabrutinib and now zanubrutinib, plus the BCL2, like venetoclax and others that are waiting in the wings. These are tremendously effective drugs that have a much better side effect profile than chemotherapy. And when you look at the efficacy profiles plus the side effect issues, it's a slam dunk to move to these. The CLL Society was started by a medical doctor, Brian Kaufman, who had become a CLL patient. And when he first was diagnosed, there was no real information out there, certainly no websites. The information was in medical speak. And Dr. Kaufman first started with a blog describing what he was learning, and he was describing it for patients. That led to the development of the CLL Society website, and most importantly, the support groups. The support groups are there to help people understand. We share our experience about our symptoms, about what questions to ask doctors, what we don't need to ask doctors because we can find on the website. The CLL Society just introduced the medicine cabinet with a picture of each of the drugs in its bottle, what it is, how it works, what the side effects are. Just an incredibly valuable resource that can save the doc's time, save their staff time. The CLL Society motto is smart patients get smart care. And oh boy, is it true. I've been on websites, other websites, where people are getting treatments that are obsolete because they weren't aware of what is going on in the major CLL centers of excellence. The CLL Society makes smart patients, and therefore they get smart care.
So you already heard about much of the stuff that's on this slide here, both in the video and in what Larry was talking about. Just a couple of points to raise here. Lots of patient and care support groups nationally, many of them are held virtually. There's expert access programs, educational events, on-demand seminars, COVID-19 action plan I'll talk about later. A whole variety of ways. So there's just on this slide information on how you can get hold of these patient education toolkits and the provider resource library. So that's on here. So there are topical support groups now available for physicians with CLL, watch and wait, veterans with CLL. Support group brochures are available upon request, and you can get those through the website that's here for the CLL Society. And there's web page information coming and available in 2024, a whole variety of non-branded information. There's downloadable handouts that can be printed on demand. You can get free hard copies which can be mailed upon request for your offices to be able to hand out. Quick links to CLL-specific CML opportunities, and again, the website's on here. So with that, we're going to go in and start thinking about seizing control in treatment-naive patients with BTK and BCL2 inhibitors, and it's a great pleasure for me to introduce John Allan from our first of the 3 New York institutions this afternoon. John, over to you.
Thank you, Professor Gribben, and thank you to CLL Society and Peerview for the opportunity and privilege to be here to give you one leg of this important seminar today on BTK inhibitors in CLL. And so I'm going to start off with the frontline data here, looking at first a case to kind of frame our discussion today. So here we've got a patient, 73-year-old female with symptomatic CLL. You can see here presenting with multiple indications for treatment initiation with B symptoms, an elevated white blood cell count of 250,000, hemoglobin 9, platelet 70, so a rise stage 4. Otherwise relatively healthy at age 73 with diabetes and hypertension and presumably well controlled, and fitness with performance status of 1. We do see, though, very high-risk disease features, del17p, an unmutated IGHV, as well as a p53 mutation on top of that, which is common, and on top of that, a complex karyotype. So very high risk, proliferative disease, and somebody who's needing therapy. And so this is not an uncommon patient. Fortunately, though, these high-risk patients only are about 20% of people at diagnosis, but they represent a unique problem because we don't really know how the best way to treat them. And right now, it's a little bit of patient preference, a little bit of physician comfort, and kind of thoughts about where the data might be moving towards. So it's an important discussion. How do we treat this patient? How do we counsel them? How do we choose between our available options, our venetoclax-based approaches, BTK inhibitor continuous therapies? And what is that expected outcome? And maybe I can just pose a quick question. Maybe Dr. Lamanna, I mean, how are you setting up these discussions with your patient? When do you do it? Kind of what is your strategy, and you know, what is your approach?
Yeah, I mean, she's obviously got high-risk features. Although patients now have very good options with both the fixed duration as well as the chronic continuous therapy, I still am a little bit leaning towards continuous therapy and BTK inhibitor-based therapy for a patient who has all the negative features, which she does. Although that doesn't mean that that's going to be her only treatment, although she is 73, and this is far better than what we used to do with chemoimmunotherapy, so that shouldn't be offered at all. And we can argue and give our opinions about the time-limited approaches as well for somebody who's high risk, but I still give chronic continuous BTK in this individual, knowing that I still might have to do something later on.
One of the advantages you have, of course, in CLL, although it's hugely important to be doing the TP53 mutation analysis right at the time you're giving treatment, is that usually you've had time to be spending time with the patient, informing them about the fact that they've got high-risk features before you get to that point. And of course, the very fact that she's got high-risk features just highlight again, it's not an indication for treatment in itself. It's still
Right.
watch and wait until you
Agreed.
get there. But you've normally got some time to get people to come to terms with the fact that they're not your everyday garden patient. So usually you've had some time to get the patient used to it. Yeah.
Absolutely. So we start planting these seeds many months, if not years ahead of time, honestly, before we make that treatment decision. So we're not surprised when we need to have this very complicated discussion. Dr. Lamanna, are you telling her that she's going to live a normal life expectancy, this type of patient with these new therapies at age 73?
Well, she is
Whatever
73.
that might be.
No, I shouldn't say
Hey, be
that.
careful.
I mean, obviously the outcomes are very good, even in these individuals with high-risk disease. Although, as I said, that doesn't mean this may be her only treatment. But the good news is we obviously do have a lot of potential salvage therapies for her. So, the fact that she is older, that it could be that she could. I mean, normally, if for a younger person, we'd say that their overall survival is likely probably a bit compromised compared to normal controls. But given the other options of other therapies sequentially, potentially, if she doesn't transform, she might be able to go from one salvage therapy to another between Ven-based therapies, non-covalent, and so on and so forth, and other clinical trials with obviously novel mechanisms of action that are exciting as well. She has potential options, so she could potentially live to her whatever age.
So you
that
see
might
a decade horizon at least.
You might be there, yeah.
Yep. Great.
Very optimistic.
And so, this brings up the question of this long-term data. How does this really inform us? How does this make us comfortable with these decisions? What are these safety considerations? And now we've got 3 available inhibitors. Which one are we using? How do we choose them? What are those differentials that we're looking for? And, we're going to see data at this ASH about anti-CD20 added to acalabrutinib that I think we got to. We can't ignore it really anymore sometimes here. So we'll talk about that. We'll see some of that data. Dr. Thompson, what is an unmet need for this high-risk patient that you see? What's an important question that you kind of want to see answered maybe in the future?
Yeah, absolutely. So I think, as we all alluded to, a lot of good frontline therapy options, and as Dr. Lamanna kind of pointed out, we don't have randomized data to make that decision, but subgroup analyses might favor a covalent BTK inhibitor continuous therapy, but a lot of emerging data also with doublet and triplet fixed duration therapies. I think one of the bigger unmet needs actually is going to come to that subsequent therapy and how we sequence these patients, especially with the emergence of the non-covalent BTK inhibitor class. And so longer-term data, not just from the initial treatment, but thinking about what the subsequent therapy should be and if we have any data to really guide sequencing.
Amazing. And so we're going to see a lot of that throughout this seminar, and this was just a nice kickoff and an initial discussion to start getting some thoughts out there and to start helping us understand and incorporate this data. So here's our NCCN guidelines here in the US that we use and follow. As you can see, we've got preferred options on the left here in the first line, and that includes acalabrutinib plus or minus Oben, Ven, Oben with Oben. It does add something, I'm very, very convinced of that, and then zanubrutinib to venetoclax particularly, and then zanubrutinib here as a monotherapy. And then, ibrutinib, still an effective drug, very effective drug, changed the world, has been moved to a second line and subsequent option, and not necessarily a first line preferred in these 3 agents. But it's there, it's available, and still, I have many patients still on this drug as well. So here is kind of some of this data that is kind of making us question the role of anti-CD20 and where does that fit into the treatment. And so we're going to see at ASH an abstract of an updated now 6-year follow-up of Elevate-TN. As a reminder, this is acalabrutinib obinutuzumab versus acalabrutinib versus chlorambucil obinutuzumab. This did include del-17p patients. And what we're seeing is each year follow-up, this difference between AG plus A continues to widen and with additional follow-up. And this is something I think I've been on record 5 years ago saying 6 months of anti-CD20 is probably not going to, we knew rituximab wasn't adding anything, but we do know obinutuzumab is the superior agent in CLL as an anti-CD20, and we continue to see this difference. And so right now we haven't been seeing these overall survival differences, but clearly patients are staying in remission. the responses are deeper, there's higher MRD, and clearly this might have some impact on a longer-term outcome. As a historical reference, 5-year progression-free survival with ibrutinib monotherapy, which set that benchmark, is about 70%. So you can see at 78% now at 6 years, the AG arm is above that. And the RESONATE-2 data, which has about 7.5 years of follow-up, the PFS median was not met yet at 57%. And so we can see that these drugs are tracking historically well along with that in the monotherapy arm. And so bringing into this question, how are we going to incorporate this? And I think we'll have more discussions and questions around this as time goes on. And please go to the abstract to see the data presented. So we also have zanubrutinib now, which will had a update over this summer. This is from the Sequoia study. This is a big study that has several cohorts in it. In this study, specific cohort here, del-17p patients were excluded. They were funneled into cohort 2 and cohort 3 of the Sequoia study. But what we see here now, a good follow-up of close to 4 years, a little 3.5 years or so, 42 months. Zanubrutinib continued to separate itself from BR. Not that this is surprising, but we're seeing that zanubrutinib as a monotherapy is performing just like we see with the other BTK inhibitors, and this led to the approval of zanubrutinib in the frontline setting with this study here. And so we, the 3.5-year mark of 82.4%, again tracking historically well with what we know from BTK inhibitors in the frontline setting as a monotherapy. The question is, does adding the anti-CD20 matter? We know rituximab does not seem to add much to ibrutinib, and this set the kind of standard for how we use BTK inhibitors as monotherapies. And because rituximab didn't seem to add to CR rates, MRD negativity rates, PFS, or long-term overall survival. There was one study with ibrutinib with obinutuzumab. Unfortunately, it didn't have the monotherapy arm, so we couldn't really glean is obinutuzumab adding to that. And so the ELEVATE study is really the one and only study that we've had that has shown an anti-CD20 benefit in terms of PFS added to a BTK inhibitor, in this case, acalabrutinib. Here is that data again, ELEVATE-TN. This is the 5-year data on the bottom half here, and you can see that it continued to widen within an additional year, now 16% difference up from, 12. So you might think, okay, let's give the anti-CD20 to the highest risk patient out there. And I think we have been tempered a little bit by, and again, confused by how to do this and to what to make of this, because it looks like early on in the ELEVATE study, the mutated patients were the ones seemingly really benefiting from the anti-CD20 with further follow-up starting at around 4 years. The unmutated patients actually started to show a difference in a benefit in terms of a progression-free survival by the addition of the anti-CD20. Matt Davids went back and looked at all of the patient factors that might predict for improved outcome in terms of PFS with the addition of the anti-CD20 and essentially found that every single patient would benefit except those with the highest risk features of complex karyotype and del-17p, as you can see on the bottom curve there. And so, again, who is that patient? Who is the right patient? It does add some complications to the treatment regimen. It is an infusional therapy for 6 months, and we do know of the B-cell depleting effects, particularly from the pandemic era, that it can have some infectious risks to it, and it's not necessarily completely benign therapy. And so I think that is the question we've been having. How low does the number needed to treat need to go before we start to really incorporate it in the face that doesn't seem to have an overall survival benefit? And so unfortunately, the highest risk patients, who I think would make it a slam dunk, the highest risk patients, if they benefited, these would be the ones that are getting it. We're not actually seeing that based on this study. So what is the data support for the del-17p patients? And so we have some benchmarks that have been laid out. I was fortunate to help lead and be a part of this pooled study that was one of the first kind of studies out there that really gave us an idea of what is a 4-year benchmark for these patients with p53 disruption. And so we pooled 4 studies that included del17p patients. And remind you, many of these frontline studies actually excluded deletion 17p, but they could have been enrolled with p53 mutations that were then found secondarily on a central review, et cetera. And we pooled all of these studies, those that included del17p, those that included that found the patients that had p53 mutations. And mind you, these are mixed studies. So some actually used it in anti-CD20, some were monotherapies, and it's a mixed population as you would expect from pooled analysis. But what we found from this, of 89 patients, which was one of the larger studies, these studies all enroll about 20 patients each. So it's really been always difficult to look at one study and make any statistical inference. So here we had 89 patients enrolled, and what we found is that the PFS of these patients at 4 years was 79%, with an overall survival of 88%. In other talks that I've done, I would then put up the Resonate-2 study, which excluded del17p patients, and you looked at the PFS at 4 years and is right around 75%. So it was the first gleaning that this high-risk feature seemingly might have been overcome. I do think that it's not completely overcome as we start to look at longer-term data, but it is clearly better than anything we've ever been able to provide for these high-risk del17p patients. This is not unique to ibrutinib. Acalabrutinib, Matt Davids led a group there looking at 65 patients pooled from those studies that included these high-risk patients, and again, found very similar PFS. I think at 4 years it was 77%. Overall survival was around 88%. And then obviously we've got Sequoia that has a cohort 2, which is all del17p included patients, all being treated uniformly, and frankly might be the best actual true benchmark of what to expect with a monotherapy BTK inhibitor in these types of patients. That has now been followed out to at this 42-month mark, and again, tracking historically well with the data that we've seen from the pooled evidence. And so I think it's overcome a lot, but I'm not so certain long-term that it's going to be there, and I do think we might start to see PFS differences as time goes on, particularly in that Sequoia study where they're all del17p. These patients are very, very high risk, obviously. 80% have the other allele mutated and are an at-risk patient population. Here is just some prospective data that is looking at from the Illuminate study and the Alliance study that enrolled del17p patients that, again, evidence that BTK inhibitor continuous therapy treatment, in this case added with an anti-CD20, is essentially overcoming an adverse PFS, because the PFS looks the same whether the deletion 17p is present or absent in these 2 cohorts. Small numbers, 20 in each study, but regardless, continuing with this idea that BTK inhibitors are overcoming this historically adverse event feature in a continuous treatment manner. So here is kind of, I summarized all of this data already. We're going to see the median PFS, since Elevate-TN did enroll subjects with p53 disruption. We're going to see this updated data, and it looks like the median PFS is met. I just showed you some median PFS that's not being met yet there. So we're seeing it being met in these higher risk patients, and so I think we got to see the data, we got to see what it looks like and try to understand it. But this is phenomenal, this is unprecedented, and really a tough thing to overcome and try to beat and to ignore as a way to treat these types of patients. So here's just I'm not going to get into this too much, but the counter to this of why we're thinking maybe continuous treatments are the best approach maybe for these types of patients. Dr. Lamanna is going to go over this much more in depth, but we see those patients with p53 disruption from the CLL14 study getting venetoclax or obinutuzumab, 1 year of treatment, stopping therapy. They are having an inferior progression-free survival, a median PFS of 4 years. I just showed you a lot of data where those patients even have not had a median PFS, now approaching about 6+ years. What we've not shown is that this is causing an overall survival detriment, and I think that's going to be an important thing to follow up long term. Obviously, if we start to see these patients having inferior survival because they transform or there's some other issue while they are off of therapy or that disease comes back more revved up, I think that's something we're going to have to pay attention to. Right now, we've never demonstrated that. So this is a very still reasonable option, and you can argue maybe a best approach. You're trying to eliminate these clones, you're getting to an MRD negative state, maybe that prevents a transformation, but is fixed duration the approach, or is there a patient group within this that we can actually do that for? So the other aspect of BTKs and the challenge of using these drugs is choosing one of them. And so what do we know? Here's the famous kinome screens. We've seen these time and time again at many of these seminars. We know ibrutinib is a pretty clean drug in terms of TKIs, but with technology, with advancements, with research, other second-generation drugs have been developed to be more selective, have less off-target effects. That, for years, was based on the potential and phase 2 data showing lower rates of all these BTK inhibitor class effects. And it wasn't until we finally got head-to-head studies that we actually really felt comfortable to ourselves and proved to ourselves that, in fact, these second-generation drugs do and have less side effects. We know that TEC plays a role. BTK hits both BTK and TEC. They are both in platelets. TEC is the main, one of the platelet activation pathways that signals through that. And so when you have a drug that inhibits both of that, you can inhibit platelets. Now, that is occurring in all of these drugs. It's not completely free and clear, and it's not completely the entire pathway there. But we see by having less TEC inhibition, less off-target BTK inhibition, you might in fact have improved bleeding and bruising. And then the lack of EGFR, we have less rash, diarrhea, these other things that seemingly have been improved with these more second-generation drugs. Here is the Elevate-RR that was first to kind of show us and prove that the hype was real, that acalabrutinib in fact has equal efficacy, because at that point no head-to-head had actually been done in terms of efficacy as well as in toxicity. But in this study, high risk only, del17p11q, relapse refractory patients, median, I think, 3 lines of prior therapies, or 2 lines of prior therapies, and what we see here, the median PFS was the same. Acalabrutinib was non-inferior to ibrutinib, but it did show, particularly in terms of AFib flutter, 9.4% versus 16% at this kind of 4-year mark. Hypertension, 9.4 versus 23%, any grade kind of new hypertension, which is maybe a unique feature of acalabrutinib in terms of the hypertension, as well as slightly less bleeding with acalabrutinib as well. And you saw less treatment discontinuations at the time mark here, 14.7 versus 21%, due to an adverse event, so a more tolerable drug. When you looked at adverse event burden scores, again, kind of in a post-hoc analysis, kind of summarizing this with longer-term data and large numbers of patients being treated, we saw that clearly AFib, hypertension, and bleeding were higher with ibrutinib, whereas we still saw headache being an issue with acala, though it's low grade, usually goes away, can be a little pesky, can be managed with caffeine and things like that, and cough, which, you know, for the most part is not a major issue or impediment by using these drugs, but it was one thing that we do see with acalabrutinib that we don't typically see with the others. Alpine was done, not to be outdone. Zanubrutinib here this was a head-to-head study in a relapse refractory patient population, 1 prior line of therapy, all comers, not just restricted to the highest risk del17p11q. And now we've got an update. We were going to see an update at this ASH as well of this, but at the previous publication that Dr. Brown actually presented last ASH in one of the late breakers, we see that the PFS at the 2-year mark favored the zanubrutinib 79.5% versus 67%. So the first time, in fact, that we saw a superior progression-free survival of head-to-head BTK inhibitors. And now, obviously, these were unblinded studies. There's a lot of kind of picking apart these types of patient populations, which are very different. And so, but at the end of the day, a phase 3 randomized study showed that zanubrutinib did have this progression-free survival benefit at this 2-year mark. What we see here is that, again, zanubrutinib proved the point that it was less toxic, and when we say that, we usually are talking about cardiovascular toxicity. That's the really big clinical problem that we see with our patients. That's the one we want to avoid. It can be life-threatening even. We see cardiovascular deaths and sudden deaths and ventricular arrhythmias. That's really what we're focused on trying to mitigate. Zanubrutinib clearly does that, 5.2% versus 13.3%. It's not zero. Acalabrutinib's not zero. We see BTK class effects of all of these agents. We just see them mitigated and less with these more second-generation, more selective drugs. Interestingly, zanubrutinib has similar rates of hypertension than ibrutinib in this study, and we can kind of continue to see this. But there's this uncoupling of hypertension and AFib, which kind of, in the ibrutinib story, always seemed to go together. As there was more hypertension, you saw more AFib. But whereas we see similar rates of new onset hypertension, we don't see the AFib coming out. Bleeding, also rather similar between this. Now, bleeding is not a major problem. It's usually cosmetic. It's usually low grade. It's bruising. It's ecchymoses. Patients can be bothered by it, though. There are many times, it's these huge, purple areas on arms that are kind of just a cosmetic issue. Their disease is well controlled, but it can be bothersome, and these are quality of life things that we need to keep in mind. But we saw similar rates with zanubrutinib and ibrutinib. There was, at the earlier time mark, a difference in that discontinuation due to AEs. Here's the Alpine follow-up now that we're going to see. Again, please go to it. I'm not, this is just for a placeholder here, so you guys can go actually see the data. The median duration now is right around this 3-year mark or so. This overall response rate was superior. You can argue the value of that in CLL in general. And then we see the deepening responses here, and the discontinuations now looking a little bit more similar between the two arms. So BTK inhibitor class effects are there, and we have to be cognizant of those. The most common AEs, hypertension, neutropenia, that seems to be a little bit of a signal with Xanu as well, though not commonly a major problem. We can usually keep patients on drug. But major differences in cardiovascular events discontinuing drug. So to summarize the safety experience, we don't give these concomitantly with warfarin. We can do it with DOACs. We try to avoid the anti-vitamin K antagonist. Hypertension, we manage with hypertensives. We're still trying to learn the best hypertensive regimen to use for our patients. And then obviously rate control, get them to see a cardiologist, manage the AFib, and you can typically manage our patients still ongoing with the BTK inhibitor and not have to flip out of the class. Monitor for that bleeding and monitor for infections. Acalabrutinib, the unique headache, caffeine, acetaminophen seems to help. Zanubrutinib, neutropenia is there, unique, and usually dose interruption and or some growth factor, and as time goes on, you clear that CLL out, you can usually see it go away. We've got pirtobrutinib available, obviously, as well, and also there's data of cycling between all of these agents, and so sometimes we just flip the one that we were in to a different agent. If it's ibrutinib, either Acala or Xanu. If you're on Xanu, maybe potentially to Acala. There's no data going that way, but there is data of Acala to Xanu. So we funnel around with these depending on the side effects and toxicities. Again, I don't want to belabor this. There are CYP3A4 issues here, so inducers or inhibitors. Be cognizant of what your patient is doing, ConMed, Rex, working with your pharmacist to identify any of these interacting meds. And then there are clear resources out there to help guide you on what should the dose be depending on the drug that the patient might be on. All right, so to recap, this is a patient on a continuous BTKI. I think there's a consensus maybe here that a BTKI continuous therapy is probably our best option right now for this type of patient. We're usually just choosing a more selective second-generation drug. That role of anti-CD20 remains unclear for CLL patients in general, but I think maybe is a little bit even murkier for the del-17p, and in fact, maybe evidence against it. Fixed duration is still a reasonable approach. What is the best fixed duration? Is it doublet combinations or other Ven-G approaches? But we'll learn more from CLL17, and Dr. Lamanna is going to talk about that. So with that, I spoke fast to get through a lot of data there, and we'll just follow up with some of the polling questions here, and we'll reassess your skills. So I'll take you through the question. Which strategy would be your first choice after seeing all of this data and some opinion on the panel here for the management of this 73-year-old symptomatic CLL, comorbid diabetes, hypertension, unmutated IgHV, complex karyotype with a p53 disruption? What are you going to do in your clinic when you go home on Tuesday? Okay, so people want to add the antibody or plus or minus. It's a plus or minus there. So most people are choosing second-generation drugs. It looks like it's steered some patients, folks away from a fixed duration approach, and looks like people made a decision finally with some of the education. So that's great. I'll just summarize this. These second gens are out there. They've improved tolerability. They look good in high-risk groups. Activity combinations are coming around. That's where our second part of this seminar is going. Overall BTKI-based regimens have really revolutionized how we're managing our lymphoma patients and CLL in particular. I'll kick this back over to Dr. Gribben to talk more about the CLL Society, I think. I think that's what we were doing, right?
Sure, exactly. Yeah, thanks.
Thank you.
Cheers. Thanks, John, and thanks also for the correction. I misspoke when I talked about the approvals for pirtobrutinib. I'm a week out of date. It was approved last week for CLL, so I said mantle cell lymphoma is approved for CLL as well. John picked it up. Megan's going to come back to it anyway. We would have corrected it, but the old fogey up here got it wrong by a week again. Never mind. Still not approved in Europe yet, so that's never mind. Anyway, so you heard a lot about the three most important tests that we have, the ones that we kind of highlighted here that John highlighted as being associated with a poor prognosis: FISH, TP53, and IgHV. These were, of course, vitally important in that era when we were still using chemotherapy. And, of course, when the new targeted therapies first came out, there was initially that thought, well, the targeted therapies overcome these poor prognostic features, but as you heard from John, they don't always overcome it completely, and we can still select which of these agents to do, so it's very important that we remember these tests. The immunoglobulin mutational status will not change over time, so it can be done at any time in the patient's history. It's one of the ones that can be done at the time of original diagnosis. It won't change. Very important you repeat your FISH and TP53 at the time you're making the decision to treat, because that can evolve. And even if you've done it relatively soon beforehand, it can always evolve right before you give treatment, and it may make you do it. So it is important, as you've heard there. When do you do them? Well, I've already talked about that, and how these tests are available. If they're working in a site that's not got these tests readily available, the CLL Society will be able to help you to identify exactly where to send these samples off. So with that said, now that I've corrected my mistake, on to the Upper West Side now for Nicole to talk about moving forward with fixed duration platforms. Thank you.
Thank you, Professor Gribben. My esteemed panel, peer review, for having me today. Much appreciated. So we're going to talk about fixed duration platforms.
Great job.
We're going to take the same patient case, 73-year-old Susan, still having obviously a marked lymphocytosis, and her hemoglobin's 9 and her platelets are 70. But now she has bulky lymphadenopathy. She does not have a deletion 17p or p53 mutation. She is unmutated. After discussing with her, because obviously these discussions become more lengthy given all our options of therapy currently, she would like to achieve a deep remission as a goal of her therapy. So, in the discussion, is achieving an MRD negative remission a useful outcome? What other goals of therapy should be discussed? What are the logistical considerations with time-limited venetoclax-based platforms? And when pairing with obinutuzumab, what are the recommendations for tumor lysis? How would you decide between fixed-duration platforms or continuous BTK therapy? And what would offer the greatest chance of MRD negative remissions? And will BTK, BCL2-based platforms play a role in this setting? What is the current practice in the EU versus US? Now, obviously, I'm going to talk about all this, but just to talk a little bit with my colleagues here, and maybe we can talk about, there's many ven-based platforms that we're going to talk about. And John, given the difference now with the EU versus the European, what do you think about this? And how have you incorporated that in your practice?
Since I left Boston and went back to London, this is the first time I can remember having access to a combination that you don't have. So this is a real unusual circumstance for me to be in. But yeah, ibrutinib venetoclax is licensed and approved in the US, gives an option of a fixed duration therapy that you don't have here yet, although I'm going to show you the data. And I know, Nicole, you're going to go through all this, so I don't want to kind of belabor the fact too much, but I can't remember discussing with a patient someone who doesn't prefer the idea or the concept of fixed duration versus a therapy for the rest of their life, unless you get the opportunity to discuss the nuances of some of the things that John talked about. So yeah, that combination then becomes a very attractive, because it lands up talking about both of those issues. You cannot use fixed duration with a BTK inhibitor alone. It does not drive deep remissions, as we know. You're no point talking about MRD to patients with BTK inhibitors. The number of MRD negative patients in those circumstances, very, very small indeed. But if it's important for a patient to have fixed duration, and it's important for them to become MRD negative, then the dual combination is an attractive way forward. And of course, you're going to go through all the data about the clinical trials that are going to address what's the right way to do it. So I won't say anything more than that.
Fair enough. Okay, so let's just go on. So just to update everybody with the CL14 study, obviously this is the time-limited approach with venetoclax and obinutuzumab versus obinutuzumab and chlorambucil. Remember, this is 12 months in duration in the untreated patient population. And here we now have 6 years of follow-up with the median PFS about 53% for venetoclax obinutuzumab versus 22% with obinutuzumab and chlorambucil. So very tremendous efficacy with this time-limited approach that has now been obviously approved and has changed our landscape. In different subgroups of patient analysis, here's the IGHV patients, and you can see here, though, the unmutated patients with venetoclax obinutuzumab does drop off a little bit compared to the mutated patients. Again, still very efficacious in comparison to obinutuzumab chlorambucil, but there is a drop-off for the unmutated folks that is noted. When we talk about MRD, and obviously that's what John was talking about, having these fixed duration platforms, there's obviously a sense of the notion that if you can get deeper levels of remission, then hopefully the response duration and time to next treatment will obviously be further away. And obviously we're going to trying to standardize how to detect MRD is an ongoing discussion with flow cytometry and NGS-based platforms, and different studies have done this differently, so you do need to pay attention when you're comparing different studies. But here in the CL14, this was done via a clonoSEQ assay, and you can see that the patients who had a greater depth of undetectable MRD, less than 10 to the -4th, obviously did better than the patients who had greater than 10 to the -4th, which is the red curve on the right. And so this is important, and you can see the comparisons between peripheral blood and bone marrow. And obviously going forward, hopefully we'll be able to, with more sensitive techniques, be able to equalize peripheral blood and bone marrow testing, so you really don't have to then be doing this on bone marrow. But I do think in some of the clinical trials where we've seen them done in both compartments has been important, so we can see that they're become more standardized and equal across. So hopefully we'll be moving away from doing bone marrows, in the future. Although they're still important, we won't get into that for certain subsets of patients, depending upon what they need. In terms of now oral combinations for time-limited approaches, obviously there's a rationale to do this because of the different complemental effect between the two different therapies. Venetoclax does a very good job at mopping out the bone marrow disease, and obviously the BTK inhibitors do a great job at reducing lymph node bulk. There's non-overlapping toxicity profiles, although to be fair, there's still some GI issues both with BTK inhibitors and venetoclax. So the GI issues are not necessarily non-overlapping. But obviously the goal would be that there would be reduced likelihood of resistance for these time-limited combinations with both these excellent drugs and the potential for highly effective time-limited therapy. Now, most of our long-term data has been with the combination of ibrutinib and venetoclax in this setting. This is the MD Anderson experience. Initially, this started, it is now 24 cycles of ibrutinib and venetoclax. Initially, it was a little bit less than that as a 12-month therapy, and then this got extended with some protocol amendments. But you could see now, and this will be presented abstract 4635 on Monday, so please stay tuned, that the 5-year outcome with the ibrutinib and venetoclax, the PFS is 90%, the overall survival is 96%. And for patients with high-risk disease, deletion 17p or p53, the 5-year PFS is 86%. And so this is excellent, an excellent combination. And then we talk about, this is probably, with longer follow-up, when we talk about time-limited approaches, even perhaps for our most high-risk patients, perhaps with oral-oral combination, we might then say, hey, maybe we won't do continuous, therapy, as we just talked about with the previous patient who had a 17p, if the results are this good. So stay tuned. But this is, achieving excellent results for patients even with high-risk disease. Now, of course, we have another study, the Captivate study, and Dr. Allan's presented this previously. This is a study that looked at both fixed duration as well as an MRD-guided cohort duration. This was 3 months of ibrutinib lead-in, followed by 12 months of the combination of ibrutinib and venetoclax. And this is in terms of an update for the fixed duration cohort here. You can see the 4-year follow-up with an excellent PFS, a 4-year PFS here of 79% for all treated patients. But you do see a drop-off with the unmutateds a little bit, and you do see a drop-off with the patients with deletion 17p or p53. Again, still being very good in the 4-year PFS for them at 73 or 63% respectively, but excellent, again, compared to chemoimmunotherapy. But of note, with the time limited, still a drop-off a little bit. Now, there also will be a update at this meeting, abstract 633, on Sunday with the 5-year update of the fixed duration of Captivate, as well as an arm that talked about ibrutinib retreatment. So here you can see there have been 53 patients who had already progressed after the fixed duration, and a subset of them, 28 of those patients, were retreated with ibrutinib. After a median time on retreatment of 17 months, the overall response in 21 of the 28 that were evaluable was 86%, the majority again being PRs and PRLs, because we wouldn't expect complete responses in just monotherapy with a BTK, but again, able to retreat those individuals who got oral-oral combination and resalvage them. So this is very encouraging data, and the overall fixed duration cohort now at 5 years of the update 54-month PFS of 70% and the overall survival at 97%. So again, very good efficacy with this time-limited combination of 15 months of therapy of ibrutinib and venetoclax. And you can see how well they do also in patients with high-risk disease, deletion 17p or TP53, the complex karyotype unmutated, with the 54-month PFS in the table on the right. Now, what about moving on to our colleagues overseas? Here's the FLAIR data that's been presented previously by Dr. Hillman. Now, this is a little different. This is ibrutinib and venetoclax in an MRD-guided fashion versus FCR in upfront untreated CLL patients. And essentially what this study did is ibrutinib was front-loaded for 2 months to then debulk, and then venetoclax got added in with the ramp-up as usual. And then the ibrutinib and venetoclax was given anywhere from 2 to 6 years. And so the way that was given in MRD-guided fashion is that patients were first tested via flow cytometry for MRD at 12 months, and then every 6 months until if they achieved MRD negativity, and then they were repeated at 3 and 6 month intervals, both in the peripheral blood and the bone marrow. And so if you had undetectable MRD at that point, what they did was they doubled the amount of time you would be on ibrutinib and venetoclax from the time you started I+V to the time of your first negative peripheral blood testing. And so they would double that time period. So you could be anywhere on the combination from 2 to 6 years of ibrutinib and venetoclax. And you can see here is obviously the PFS of I+V versus FCR was superior. At 3 years was 97% versus 77%, and at 4 years, 94 versus 65%. The overall survival, again, favoring ibrutinib and venetoclax. At 3 years, 98 versus 93% with FCR, and at 4 years, 95 versus 87%. So an MRD-guided ibrutinib venetoclax versus FCR. This is the GLOW data. This is what Dr. Gribben was referring to. This is what led to the approval, the EMA approval of ibrutinib and venetoclax in Europe. This is in an older, unfit patient population of I plus V for 12 months versus chemoimmunotherapy. And you can see that the PFS was certainly better than chlorambucil obinutuzumab. However, just of note, there was 4 on-treatment fatal cardiac-related AEs, and we'll talk about some of this when we talk about, as I go on further, but that's important to note in this older patient population. The Gaia study, or CLL13, looked at doublets and triplets. So this was a study that looked at venetoclax obinutuzumab or venetoclax obinutuzumab and ibrutinib versus chemoimmunotherapy versus venetoclax and rituximab. And the venetoclax obinutuzumab or venetoclax obinutuzumab ibrutinib had a better PFS compared to chemoimmunotherapy or venetoclax and rituximab. And the majority of those patients on either Ven-G or Ven-GI were able to achieve undetectable MRD at an earlier time point, and obviously this will need to be followed, but you could see that the PFS, again on the right, is better for those individuals who achieve 10 to the minus, greater than, under 10 to the minus 4th or better compared to those on the red curve. So achieving deep levels is important for PFS. About the safety combinations, when we look at this, the phase 3, the GLOW, an older patient population versus the CAPTIVATE, a younger patient population. In terms of the GLOW data, again, notably, obviously, the cardiac issues were related to the ibrutinib. For the ibrutinib venetoclax, the infectious complications are notably for both. So do not think that just because you get chemo versus orals that you can't get infectious complications with the oral agents. I think that's important. With the CAPTIVATE data, you see some neutropenia, hypertension, and infections. The grade atrial fibrillation was a little bit less, with the younger patient population compared to the GLOW data. So I do think, the ibrutinib venetoclax also easier to administer in some respects because of the debulking with the lead-in with the ibrutinib, which reduces the TLS when you use venetoclax. But certainly these are very highly effective strategies, but you need to consider safety, particularly in older individuals. So with venetoclax adverse events, John talked about, obviously, the BTK adverse events of special interest. Venetoclax has its own issues. There's more myelosuppression because it's the ability to clear out the bone marrow more effectively than the BTK inhibitors. So you do see more neutropenia. You can see more thrombocytopenia as well. You can give growth factor support and dose reductions accordingly. I think infection complications, no matter what, for our CLL patients on therapy, always need to be monitored. Certainly, if there are severe infections, we advocate holding the therapy during that time period. GI issues, there's more diarrhea and nausea with venetoclax, although you can see diarrhea with the BTK inhibitors, as I noted previously. Most of that is very amenable to supportive care measures with anti-nausea medicines and anti-diarrheal agents. And then tumor lysis monitoring, as you all know, due to this prolonged ramp-up that we have with venetoclax-based therapy, you need to monitor for tumor lysis. And depending upon the amount of bulk of disease, starting with the, whether they're high risk, intermediate, or low risk, will sort of dictate what you need to do, whether it's outpatient or inpatient management accordingly, with pre-medication with antihyperuricemics, adequate IV hydration, so on and so forth. If you're going to use venetoclax obinutuzumab, usually initiate the venetoclax a little later. We know obinutuzumab can cause infusion reactions, can also cause some tumor lysis in and of itself, so you'll start that later on, but it's a great debulker also for venetoclax-based therapy to initiate the obinutuzumab first. Less so with rituximab, and so people oftentimes will start that simultaneously, although you could also start it later as well. And then again, you're going to look at, just similarly to when you look at BTK inhibitors, you're going to also look at what other medications your patients are on in terms of dose drug-drug interactions regardless. So what about the data with fixed duration combinations with second-generation BTK inhibitors and venetoclax? So obviously you're seeing maturing, emerging data on doublets and triplets with the newer generations, and so here's AVO, acalabrutinib, venetoclax, and obinutuzumab. This was a study done by Matt Davids in treatment-naive patients. These were high-risk patient population. 60% of them had a TP53 or deletion 17p. 24% were complex karyotype, and the majority were unmutated. Very active. Bone marrow undetectable MRD was 83% in TP53 aberrant patients, and durable responses seem to be so far with 93% PFS at a median follow-up of 3 years. There were low rates of cardiac and infectious toxicities, and you could see that the bone marrow MRD tended to improve over time. This is some of the safety data with the triplets. There's more grade 3-4 neutropenia, thrombocytopenia, and anemia with the triplet combination, so you do have to pay attention to that when you're adding agents together, of course. They had grade 3, some mild grade 3 non-COVID infectious complications, pneumonia and colitis. Obviously, this was done also during COVID period, so there was 9% of COVID infections. Low cardiac issues presently on this study. Obviously, this isn't head-to-head comparison to ibrutinib combinations, but you could see with acalabrutinib, low ventricular or atrial fibrillation. There was no febrile neutropenia or opportunistic infections and no major bleeding issues. And there was about a 20% dose reduction that was needed. Here's with ZVO or zanubrutinib, obinutuzumab, and venetoclax in the bovine study, a small patient population, 39 patients. About 13% had TP53, so not as heavily enriched for high-risk individuals as the prior study. 72% were unmutated, median follow-up but less mature at 26 months. 89% were had undetectable MRD, and again, the adverse events, more thrombocytopenia, fatigue, neutropenia, and bruising noted, and grade 3 neutropenia. So more cytopenias when you add these agents together, particularly when you add obinutuzumab to venetoclax. So keep that in mind. There are some newer studies that will help us address these platforms going forward in a more randomized fashion. Here's CLL-17, looking at ibrutinib versus venetoclax obinutuzumab versus I plus V, venetoclax and ibrutinib. And this is for previously untreated, fit and unfit patients, and will include patients with deletion 17p or p53. So finally, we'll have a randomized studies of monotherapy versus time-limited, either ven-ob versus I plus V. Here's CLL-16, which will look at venetoclax and obinutuzumab versus AVO, so acalabrutinib, venetoclax, and obinutuzumab in high-risk individuals, so including deletion 17p or complex karyotype, and again, previously untreated. And then we have the AMPLIFY study, which is acalabrutinib and venetoclax plus or minus obinutuzumab versus chemoimmunotherapy in treatment-naive CLL patients. These will not include high-risk individuals, will not have deletion 17p or p53, and the combination will be AV or AVO for a year, time-limited in general versus FCR or BR. And then we have the MAGIC study, which is more of an MRD-guided approach of looking at a time-limited platform, so looking at acalabrutinib and venetoclax versus venetoclax obinutuzumab. Again, they will be MRD-guided, so if you achieve undetectable MRD, you will stop either arm. If you have ongoing MRD, you will continue either AV for another 12 months, or you'll continue venetoclax for another 12 months. We're also seeing some emergent data with non-covalent BTK inhibitors, and Megan will talk more about this, but in the Bruin study with pirtobrutinib, they had some small cohorts of pirtobrutinib and venetoclax and a small number of patients, 15, and then PVR, pirtobrutinib, venetoclax, and rituximab in 10 patients. The overall response was high. And so fixed duration pirtobrutinib has been now combined with venetoclax and rituximab, and there's an ongoing phase 3 study currently enrolling patients looking at pirto ven ritux versus ven ritux a la the Murano study, and there'll be an ASH update at abstract 3269 on Sunday, so stay tuned for that as well. So let's go back to Susan. So now you have, she's 73. She has the same comorbidities. She has bulky lymphadenopathy. She does not have a 17p or p53. She is unmutated, however, but she would like to get, her goal is a time-limited approach or MRD. So here, Vengi is a very good option for this individual. Alternatively, you could give chronic continuous BTK. However, she wants to achieve MRD and get off therapy. And then, of course, BTK ven is certainly an option, although recently approved in Europe, but not yet approved here in the US. And so they wait additional data from some of these other phase 3 studies with the combinations. And so be on the lookout for those. And debulking with a lead-in ibrutinib can reduce the risk of tumor lysis, making it a little bit more feasible and easier when you combine that with venetoclax, giving the ven obinutuzumab complicated ramp-up. So let's follow up with a polling question. I think I got us back a little bit on time. So you have, again, 73-year-old Susan, symptomatic CLL, bulky node. She's unmutated, no deletion 17p. In order to achieve a deep MRD negative remission, what strategy would you now recommend? any covalent BTK inhibitor, acalabrutinib and obinutuzumab, venetoclax, obinutuzumab, chemoimmunotherapy, I'm not sure. You want to get back up again?
It was an easy way to do it, and then I can introduce Megan.
Yeah. Great. So it looks like any covalent BTK inhibitor
You did your job.
and post. Good. Look at that. The majority venetoclax, obinutuzumab, fixed duration. Okay. And then, another follow-up question. Can you accurately summarize outcomes from the fixed duration BTK BCL2 based experience reported in the MD Anderson or Captivate trials? So are durable responses and robust PFS overall, but not in deletion 17p. Durable responses and robust PFS overall, but not in unmutated CLL patients. Durable responses and robust PFS in all patients, regardless of high-risk features. High initial responses were transient over time. Impact on PFS is uncertain, or I'm not sure. That's a little bit of a tricky, unfair question.
That's a mouthful.
See how much they were paying if that was your fault? Oh, okay, good. So So it seems like durable response, robust PFS in all patients. I mean, if we get really nitpicky, we know there's a little bit of drop off, as I noted, between the 17p and the unmutated, but still really, really good efficacious therapy. So, okay, very good. So final thoughts. Fixed duration Ven-Ob included in practice guidelines. That is true, and preferred option for treatment-naive CLL patients with ability to achieve deep MRD negative responses. The BTK-Ven combinations are rapidly emerging and show encouraging efficacy. Ibrutinib-Ven is approved in Europe. It is not yet approved here in the US. And finite therapy with Acala or Xanu combined with venetoclax is being assessed. And of course, doublets versus triplets is a whole nother question about what might be better. And when discussing with patients, consider goals of care, toxicity profiles, and logistical aspects of time-limited therapy. And with that, I will bring Professor Gribben back up. Thank you.
Great, thanks. Actually, it is interesting because in Europe, the case you described is exactly the case we probably would use venibrutinib with, because the Ven-G does have that drop-off of the... So I'm using Ven-G for mutated and Ven-I for unmutated. It does come with the downside, of course, that I'm back to using ibrutinib, which is no longer my preferred frontline BTK inhibitor, and I don't have access to use the others in the combination. Anyway, I'm back to talk again about the CLL Education Toolkit. It does contain a whole variety of information about the biology of the disease. And I think another thing that we all enjoy about looking after CLL patients is now how well informed most of the patients are about and being able to be involved in their own decision making, which I think is something we all find incredibly rewarding, to be able to have a really deep discussion with our patients about what's the choice that they want. And again, you can get this information at the website looking at the Patient Education Toolkit. With that, we're back to the East River, and Megan's going to talk to us about non-covalent BTKIs, remind me that I'm wrong about pirtobrutinib's approval, and look about other innovative options. Thank you, Megan.
All right, thank you. So I'm going to take us a step forward and really talk about sequential treatment, the relapse setting, and then some of the emerging and even now approved strategies.
Some questions coming in.
So we now have a patient, switching gears, a different patient. Kevin is 80 years old. He was diagnosed with CLL 10 years ago. So this case is really going to speak to the chronic nature of the disease and how we sequence therapies over time. So initially, he had a period of active observation, then had symptomatic CLL, warranting treatment initiation back in 2016, and was treated with first-line ibrutinib. After a few years on therapy in December 2020, he relapsed on ibrutinib, so disease progression on a covalent BTK inhibitor, and then was treated with venetoclax rituximab as a fixed-duration therapy of 24 cycles of venetoclax per the Murano regimen. After finishing treatment, 9 months after end of treatment, he had progressive disease in September 2023, and now we're tasked with selecting his next line of therapy. So in terms of cytogenetic and molecular features, no TP53 aberrancy, the presence of deletion 11q, unmutated IGHV, and also Kevin's had slowly declining performance status with an ECOG performance status of 2 currently. So some points to address, kick us off with discussion are, could you re-expose this patient to venetoclax? What about switching back to a covalent BTK inhibitor in this setting? So maybe Dr. Allan, I don't know if you have any preliminary thoughts about this case in these first 2 questions.
Yeah, I mean, I think, remind me, the remission was?
Yeah, it was only 9 months. So finished Ven-R, and then 9 months later had not only CLL relapse, but CLL warranting initiation of therapy.
Yeah, I mean, I think that's always the crux of the matter, and we don't really know. You know, the consensus is less than 2 years. People typically would not retreat. I've had some patients that have progressed soon after stopping the drug. I have restarted. I have gotten some, remissions, but then you seem to, there's something resistant about that disease. So particularly with a 9-month remission, I'm kind of moving on and switching out of the class and going to a different agent.
Yeah, and then I think this is an important point. So Professor Gribben, for someone who's progressed on a covalent BTK inhibitor like ibrutinib initially, then gets treated with another regimen, would you ever cycle back to the covalent inhibitor?
Yeah, that's a great question because, of course, there is some data suggesting that some patients treated with venetoclax, you can eradicate the original resistant clone. I think unless you've got good access to having good mutational analysis, and if you've got that, you could consider going back to it, but I think you really have to have that kind of data available, like you did in Ohio.
And then thinking ahead, and we'll review some of this data, but Dr. Lamanna, what do you think about non-covalent BTK inhibitors in this setting, and kind of what has the clinical experience been with non-covalent BTK inhibitors in CLL? And we'll kind of review the data in detail, but just prelim clinical experience thoughts.
Yeah. No, I mean, the data is very good. For those of us who participated in the Bruin study, these patients did really, really well. Mind you, she's going to go over this data, but certainly this is a very good patient example where we could use this agent going forward, or this class going forward, I should say, since there's more than one agent.
I know you're going to present the data, but I think what struck us all from the very first time we've seen it is the side effect profile of this agent looks quite different, doesn't it?
Correct.
Absolutely. So just to review, because this patient progressed on ibrutinib, we now know that in the majority of patients at the time of clinical progression on ibrutinib do have mutations in the cysteine 481 position of the BTK protein, which is where the drug binds BTK. And then a smaller subgroup of patients also have mutations in PLC gamma 2, which is the protein immediately downstream of BTK in the B cell receptor signaling pathway. These mutations, BTK cysteine 481S being the most common, is a catalytically activating mutation and leads to downstream B cell receptor signaling. And we're seeing more emerging data about resistance, not only with ibrutinib now for covalent BTK inhibitors, but also with acalabrutinib. So here is data presented at ICML. This is the Elevate-RR cohort. So we saw the clinical trial data for this earlier in the presentation. But you see side by side BTK mutation resistance profiles for acalabrutinib and ibrutinib, small numbers of patients still. You can see that cysteine 481S mutations were dominant with both groups. However, there are many co-mutations also that you see here co-occurring, for example, T474I in the acalabrutinib cohort, as well as, for example, L528W in one patient with ibrutinib. So patterns really of mutational frequency, VAF, and uncommon variants varied a little bit between acalabrutinib and ibrutinib. And here you see a diagram of the B cell receptor signaling pathway, and you see protein maps actually of BTK at the top there, and there's a bunch of mutations that are outlined here, and this is for covalent and non-covalent inhibitors. But I think what this really highlights is that There are mutations outside of the cysteine 481S binding site mutation that was most common in the initial resistance studies with ibrutinib. And we have seen cysteine 481S mutations now in patients treated with acalabrutinib and zanubrutinib. But there's also other mutations that have different functional consequences emerging too with covalent BTK inhibitors. So for example, still really small numbers of patients, but 13 zanubrutinib treated patients at the time of disease progression with sequencing. Not only were cysteine 481S mutations detected in 10 of 13 patients, 7 patients progressing on zanubrutinib also had an L528W mutation. So BTK resistance mutation is certainly not standard of care currently and does not currently determine clinical practice, but I think this research is important, and in the future it might have some implications in terms of how we select different covalent inhibitors and how we sequence between covalent and non-covalent inhibitors. So here you see the most recent NCCN guidelines. And this is in patients without del17P or P53 mutation, so applicable to the case we initially discussed. And for patients who previously had a covalent inhibitor, a couple of options to highlight and walk through the data, venetoclax, venetoclax retreatment, and the non-covalent BTK inhibitor pirtobrutinib. So we know that venetoclax is active in ibrutinib refractory CLL. This is a study published back in 2018, a phase 2 study of venetoclax. Is venetoclax monotherapy in patients with CLL treated with prior ibrutinib specifically, heavily relapsed refractory patient population, median of 4 prior therapies, and a high overall response rate, 65%, and including a 61% overall response rate in the TP53 aberrant subgroup. Here is data from the phase 3 Murano study. We've talked about this data throughout the presentation today. And this is, again, venetoclax rituximab as a 24-month fixed duration therapy in the relapse setting. You can see PFS and OS curves here. Overall superior compared to the chemoimmunotherapy control arm of bendamustine rituximab. And we will highlight, though, that in the TP53 mutant subgroup, there does still appear to be a significant difference between the median progression-free survival for TP53 aberrant disease, so median PFS of 37 months versus 57 months for wild type. And I'll also highlight when we talk about the Murano study data that only 5 of the 196 patients in the venetoclax rituximab arm had prior B-cell receptor inhibitor therapy. We now have real-world evidence as well as the evidence I just showed with the clinical activity of venetoclax following BTK inhibitor therapy. But this data was done at a time when really these patients were receiving prior chemoimmunotherapy. I want to highlight some updates from the Murano data that will be presented on Saturday. This is a follow-up of the Murano study, and really what's nice about this abstract is that we're getting more data on subsequent therapies and the second PFS event, and I think this is a really important endpoint when we think about sequencing therapies in an era of fixed duration therapies. So compared to BR, there was a significantly prolonged time to the second PFS event in patients treated with venetoclax rituximab. And then we have some subsequent therapy data. So again, these patients really didn't receive prior B-cell receptor signaling inhibitors, but in the patients who did receive BTK inhibitor now after completion of Ven-R, high overall response, 86% in the Ven-R cohort. And then there's some updated venetoclax retreatment data, which I think is really important too, and we'll talk more about in this abstract. 42 patients retreated, 32 with a response, so 76% overall response to Ven retreatment. This is data from an international multi-center retrospective study that we conducted looking at venetoclax retreatment. This was a heavily relapsed refractory patient population. Patients could have received venetoclax in any line of therapy and then received a subsequent venetoclax based regimen in a later line of therapy. We found an overall response rate of ven retreatment of about 80% in this cohort, including 56% of patients with prior BTK inhibitor exposure, so really a double exposed patient population cohort. And in a short median follow-up of 10 months, the median PFS for ven retreatment was 25 months. These patients had a median time of 16 months between the completion of ven 1 and ven 2, and I think this is a question that Dr. Allan was alluding to. We don't really know the optimal duration before venetoclax retreatment, and I just want to highlight that there's many prospective studies going on examining venetoclax retreatment following frontline ven, which I think is going to be particularly relevant moving forward. So enter non-covalent BTK inhibitors, which may address some of the limitations that we've seen of covalent BTK inhibition. So we've talked about acquired resistance, which is a problem with the covalent inhibitors. BTK inhibitor intolerance has become less of an issue with the second-generation inhibitors, but we do still see patients discontinuing despite the availability of acalabrutinib and zanubrutinib. And then we have this new challenge that we're being faced with in the clinic. That's really this double exposed CLL patient, a patient who has had already a covalent BTK inhibitor and venetoclax and needs additional therapy. And this has been a historically poor outcome group, as highlighted earlier in the presentation. So pirtobrutinib, nimtabrutinib are two of the examples of the non-covalent BTK inhibitor class. I'm going to focus mostly on pirtobrutinib, which we heard is now FDA approved for CLL after BTK and BCL2 inhibitor therapy. It's a highly selective non-covalent BTK inhibitor. It binds reversibly to the BTK protein, which distinguishes it from the covalent inhibitors. And this is the waterfall plot from the Bruin phase 1/2 study. Looking at patients, all of these patients had prior covalent BTK inhibitor therapy. And you can see in the light blue and dark blue, these patients may have discontinued the prior covalent BTK inhibitor for either toxicity or disease progression. High overall response rate, 82%. In the double exposed patient population, very high overall response rate, 79% as well. And I will say that the responses were seen regardless of cytogenetic and molecular characteristics. And of particular interest, patients with BTK cysteine 481S mutations have responses to pirtobrutinib. Here we see the PFS data. So at a median follow-up of 19 months, we have a median PFS of 19.6 months here. And we see that pirtobrutinib is efficacious in patients who are that double exposed cohort, so prior BTK inhibitor and BCL2 inhibitor therapy. Here we have a median follow-up of 18 months, median progression-free survival of 16.8 months. And these responses, when we compare to historical retrospective data for double exposed patients, this is quite a good outcome. So now we're going to see at this ASH meeting some longer follow-up of the Bruin study, about 30-month follow-up currently. And we see durability of responses with pirtobrutinib, really regardless of prior BCL2 inhibitor status. So in the presentation, you're going to see patients not only the overall response rate, which is 72%, but looking by prior BCL2 inhibitor exposure. So in the naive patients, median follow-up of 22 months with an overall response rate of 83%. At a median follow-up of 15.9 months, overall response rate of 79% in those with prior prior BCL2 inhibitor exposure. Professor Gribben was alluding to the AE profile of pirtobrutinib specifically, and here we highlight AEs of special interest, really AEs that have been characteristic of the covalent BTK inhibitor class. You see the most common grade 3 or higher adverse event is infections, which is a common challenge given this is a cancer of the immune system. Neutropenia follows that at 26% of patients having grade 3 or higher neutropenia. The Bruin study did allow growth factor use, and so the neutropenia experience can be managed with growth factor. And then low rates, in particular of grade 3 or higher bleeding, a grade 3 or higher atrial fibrillation, and grade 3 or higher major hemorrhage or hypertension. So we do know that patients despite this outstanding data, do have progressive disease on pirtobrutinib therapy. And this is work done from a cohort at our center of relapsing patients on pirtobrutinib. At the time of clinical disease progression, we sequenced these patients with a particular focus on the BTK protein and saw the emergence of BTK mutations outside of that cysteine 481 position. You can see there is some heterogeneity here. In this cohort, L528W was the most common but small number of patients. These mutations cluster around the tyrosine catalytic domain of the BTK protein, and we also had several patients with pre-existing PLC gamma 2 mutations that persisted at the time of disease progression on pirtobrutinib. At this ASH, there's some updated data that's going to be presented from the Bruin experience by Dr. Brown. You see here 86 patients from the Bruin study with disease progression on pirtobrutinib. The response to pirtobrutinib in this cohort was high overall, 83%, and many patients did have pre-existing BTK cysteine 481 mutations at baseline that actually cleared during treatment with pirtobrutinib, and that's been shown in a couple of settings now. But I just want to highlight that overall, there were BTK mutations that emerged at the time of disease progression on pirtobrutinib. In this study, T474 position mutations were the most common. There are also 27 patients who didn't have acquired mutations at the time of disease progression, highlighting alternate resistant mechanisms to be further elucidated for patients with CLL progressing on pirtobrutinib. So what are the next steps for pirtobrutinib in CLL? Well, just 7 days ago, we now have this FDA approved in the US as monotherapy in the relapse setting. There are ongoing phase 3 studies, so I'll start with the 321 study. This is pirtobrutinib versus investigators' choice of a PI3 kinase inhibitor, idelalisib plus rituximab, or bendamustine rituximab. This is in the relapse setting. We saw the preliminary data of the PV and PVR from the small Bruin cohort, and Dr. Lamanna highlighted that there's a phase 3 of PVR versus the Marana regimen in relapse CLL. And then there's also an ongoing study in untreated patients with CLL, excluding those patients with deletion 17p, of pirtobrutinib monotherapy versus bendamustine rituximab. And just to highlight, although we don't have the time to focus on Richter's transformation, which really remains one of the greatest unmet needs in this patient population, there may be a role for non-covalent BTK inhibitors in this disease as well. And so the Bruin study does have a pretty large cohort for such a rare disease, 82 Richter's transformation patients treated with pirtobrutinib, with an overall response rate of 50%, including some complete responses, 13% of the patient population. This is a heavily pretreated Richter's transformation patient population. Most patients had a prior Richter's directed therapy, and you can see the overall survival curve over there. Still a lot of work to do in Richter's transformation, but I think this data to date in such a large cohort supports further investigation with pirtobrutinib in Richter's transformation. So double exposed versus double refractory, we started to throw these terms around. And so what we mean by a double exposed patient, I would propose, is a patient with CLL relapsed after exposure to both a covalent inhibitor and venetoclax, but it does really start to matter whether this patient had disease progression on that agent or, for example, discontinued venetoclax for completion of a planned fixed duration therapy, and might not be resistant to that drug class. So a double refractory patient is really one who's had progression on both agents, a covalent inhibitor and venetoclax. And we've talked about this, but to hit home the point, the optimal treatment-free remission to be considered refractory versus exposed is still debatable. We've talked about with venetoclax retreatment, for example, maybe 24 months or 2 years is a good time point, and that's been suggested by expert opinion, but we really don't have any data to guide, what is the optimal duration or treatment-free remission where we can consider venetoclax retreatment, for example, or switch gears to another drug class. So I'm just going to throw this slide up there. We don't have time to go into the novel approaches for double refractory CLL, but Professor Gribben is going to highlight some emerging data from this ASH meeting of novel mechanisms of action. We've heard about non-covalent BTK inhibitors, CAR T-cell therapy. There's data, for example, for Lysocell in this setting, BTK degraders. There's going to be some data at this meeting presented. And then we've also have ongoing studies of bispecific antibody therapy in patients with CLL. So let's bring it back to our case with Kevin, our 80-year-old patient who has now progressed on not only ibrutinib, but progressed shortly after 9-month treatment-free remission after venetoclax rituximab. I would say, given the short duration between the end of treatment with venetoclax rituximab and now relapse that requires treatment again per IWCL criteria, we should change drug class because it might be more effective than venetoclax retreatment. And now we do have the non-covalent BTK inhibitor pirtobrutinib available in the United States, and we just reviewed that there is data to support its use in this double refractory setting. And pirtobrutinib has been generally well tolerated with a low rate of discontinuation for toxicity. So here's our polling question. The first polling question, we have an 80-year-old patient with relapsed refractory CLL, unmutated IGHV, no deletion 17p, and a performance status of 2. First line ibrutinib followed by Ven-R. How would you now treat this patient? Okay, good. So 88% are going to sequence to pirtobrutinib, which is now available in this setting. So in which of the following CLL treatment settings would you now consider using a non-covalent BTK inhibitor, such as pirtobrutinib? And for this question, you can select all scenarios where you would consider pirtobrutinib or non-covalent BTK inhibitor use. So we have discontinuation for intolerance, after progression on a covalent inhibitor and subsequent venetoclax, after discontinuation of a covalent inhibitor for resistance, so a patient with a BTK cysteine 481S mutation, after progression on a first-line covalent BTK inhibitor Ven combination, or you would consider using non-covalent inhibitors in all of these settings.
Sponsor flow.
Okay.
See?
Good. So the percentages here, because you could select multiple options, don't add up to 100%, you'll see. But we actually have the majority of the audience here considering non-covalent BTK inhibitor use in all of these settings. So with that, we have some final thoughts on sequential therapy, December 2023 in CLL. So following progression on a covalent BTK inhibitor, we've seen data to support treatment with venetoclax or a non-covalent inhibitor. In double-exposed CLL, if the patient had a longer treatment-free remission, and we threw around that 2-year number, but we really need more data, venetoclax retreatment is an option. For patients with less than 2 years or a shorter treatment-free remission, the non-covalent BTK inhibitor pirtobrutinib is an option. And really in that double refractory patient population, progression on a covalent BTK inhibitor and venetoclax previously, pirtobrutinib is an option in many clinical trials. So with that, I'm going to pass it back, and we're going to hear about some of those new options.
Thanks, Meg. So what CLL Society calls its medical cabinet is 9 of the most common medications. It's a non-branded, patient-friendly handouts that can be printed on demand to provide information. You can get free hard copies that are available on request to have on hand in offices. And again, you can visit this on the website under the medicines cabinet, and you'll see these very nice information sheets that contain a lot of information that will be very useful for your patients considering these agents. So I've got the task of talking about where we might go in the future, and of course I could have spent the whole 2 hours talking about, any of the four of us could have spent the whole next 2 hours talking about where we think it's going in the future. So what we've elected to do here is just focus on some of the presentations that you'll see, and ask just to point you to those presentations if you think that's interesting. What we're thinking about are the emerging BCL2 inhibitors in the same way that we've got multiple BTK inhibitors. At the moment, we've only got venetoclax as a licensed BCL2 inhibitor, but there's other emerging BCL2 inhibitors that are there. We've got dual activity BTK inhibitors. That is, we've heard about covalent and non-covalent, and you're going to be hearing at this meeting about the covalent, non-covalent dual activity. And of course, in our questions there, summary, Megan did discuss, of course, already immunotherapy and things like the bispecifics. But of course, where do T-cell engagers and other cellular therapies fit into the landscape in CLL? So sonrotoclax is a combination partner, looks to build upon that synergy that we heard about between BCL2 and BTK inhibitors. It's a BH3 mimetic that binds to and inhibits BCL2 with a potency that's reported to be very significantly higher than that in venetoclax in biochemical studies. And Contan's going to be presenting data on this on Saturday, looking at a phase 1-2 study in treatment-naive patients with CLL, looking at it in combination with zanubrutinib. No surprise they chose that agent because, of course, it's the same company making both, but it's a very logical conclusion to be looking at a BTK inhibitor in combination with this. Median follow-up still short, median follow-up on the abstract at least 8.5 months, and I'm going to be interested to see what Con's got to say in terms of the follow-up data we've got here. High overall response rates, as you see, occurring across all doses, and no progressions reported in either cohort at this stage, but of course, longer follow-up needed, as I've already said. Jennifer Woyak is going to present data on LP168, which is a selective next-generation BTK inhibitor. This one is very different in its action, in that it binds both wild-type and a C481S mutated BTK in a covalent and non-covalent way. And Jennifer's going to present data hypothesizing that this allows efficacy against cells with both wild-type BTK through its covalent activity, while preventing expansion of those common resistant mechanisms through its non-covalent activity. So again, interesting class of activity. Again, follow-up relatively short, but in the abstract at least, we see Jennifer presenting the data showing high response rates and quite impressive durations of response for most of the patients presented. And again, those of you interested to see that, Jennifer's going to be presenting that in a talk right after Contan's data on the BCL2 BCL2 novel combination. ROR1 is an agent that's been around for a long time. It's very appropriate we're talking about it in San Diego. Tom Kipps did a lot of their very original work for this, of course, at UCSD just up the road here. And ROR1 is an oncofetal protein. It's highly expressed on hematologic and solid tumors with little expression on normal tissues. And NVG111 is a first-in-class humanized tandem T-cell engager or bispecific antibody targeting ROR1 with CD3. It exclusively binds to the ROR1 physical domain. There's earlier evidence suggesting that the avidity of NVG111 monotherapy and in combination with ibrutinib, we know that the monotherapy is able to induce a reduction in disease burden, and now they're looking at time-limited exposure leading to durable responses in patients. And again, this also one follows right after those other two presentations. So if you find any of this of interest, you can sit through a 45-minute session of getting all three presented for you. Tanya Siddiqui's presented this data before. Lots of us presented this data before, the Transcend CLL-004 study. It's very appropriate to consider, of course, that the very first adult patients treated with CAR-T by Carol June were those CLL patients. I say that those two patients have been written up in more prestigious journals than any of us can even dream about. But it's still only those two, and we still do not have an approved CAR T agent. I'm going to say, I hesitate to say we don't have an approved agent, having made a mess up over the previous one, but we still do not have an approved agent. Liso-cel, of course, is the most widely studied of the CAR T agents, of course, alone or in combination with ibrutinib. And Tanya's going to be presenting an updated data looking at the outcome of the patients on the CLL-004 study. And she's going to present data showing the primary endpoints now been met, that an 18.4% CR/CRI rate in patients with relapsed refractory CLL after both BTK and venetoclax failures, so Megan's combination of the dual refractory patient population. And with longer follow-up, liso-cel continues to demonstrate durable CR rates with high undetectable MRD rates in patients with heavily pretreated high-risk CLL, and we look forward to seeing that abstract presented also. The CLL Society does have resources already available for CAR T, even though, of course, at the moment it's only available for the CLL patients in the setting of clinical trials, explains what CAR Ts are in a patient-friendly term, viewable online in a digital flipbook format. You can get free hard copies again, or you can visit the CLL Society or /CAR T. And there's a CAR T ambassador program that connects patients who are considering CAR T with someone who's already been through it. And I think we all know how useful that can be for our patients to have the opportunity to speak not to one of us about the experience, but about another patient. CLL Society's COVID-19 action plan, every single time we think that the COVID-19 pandemic is over, we've got another variant emerging. There's another variant emerging right now. This encourages patients to create ahead of time. Of course, it's very appropriate to consider that most of us consider that the worst days of COVID are behind us because we've been vaccinated and have high levels of immunity. Lots of our CLL patients do not fall into that category and remain highly vulnerable, and many of our patients still pretty much locked at home. And the more people outside in the rest of the community have thought about COVID-19, the more exposed our CLL patients who do not have immunity are. So this includes information about planning checklists, household quarantine plans, checklists for what to do as soon as you test positive, and of course our CLL patients often being able to access therapies very early in the emergence of COVID symptoms appearing here. So just a reminder to please do mention the CLL Society to your patients. I think we all know that our CLL patients are among the patient group that I see who are most eager to know about what they can do about diagnosis. I can barely think of a CLL patient who hasn't been engaged in some way with the CLL societies and isn't already well informed. And sometimes your heart sinks when you see them walking in with more New England Journal papers under their arms as they sit down and plonk them on your desk. You know this is not going to be a short consult, but a very rewarding one nonetheless. Visiting that CLL Society website does provide even more empowerment to ease their anxiety, and a whole variety of free resources available, as you see here. So with that, I get to now have my fun part, which is to start firing questions at the three of them. So let's keep going with it. And do keep coming in with those questions, but I can see on the pad here we've got lots and lots of these questions already coming in.
Yeah.
We talked a lot about venetoclax fixturations, but of course venetoclax was originally designated for continuous therapy. So you've got a patient who gets to the end of a fixturation approach. Do you continue venetoclax? Megan, you're thinking there.
I think that's a great question. I think, we still do have the option to do venetoclax monotherapy in the relapse setting. And there are certain patients where I still do consider that. Sometimes patients with P53 aberrancy, you wonder if continuing the venetoclax, we talked about that continuous first fixturation. I think there's still a lack of data to compare the approaches, or there's patients that just for whatever reason couldn't get the anti-CD20 antibody therapy. So if they didn't follow the Marano regimen and didn't get an anti-CD20 in the relapse setting, I have continued venetoclax. there are a lot of clinical trials that are investigating this. You know, should we be testing MRD and guiding the duration of venetoclax with MRD testing? That's certainly not standard of care practice in the clinic. For most patients, I do stop in the relapse setting at, as standard of care at that 24 cycle mark. But I think we're going to see a lot of emerging data in the frontline and relapse setting about whether, MRD might be a tool. While it's not used to determine practice in the clinic today, in the future that might help us decide continuous or shorter or longer duration.
Yeah, I mean, I think this is one of our challenging issues that we get asked about from our patients all the time. Are you testing our MRD? What are we doing with it? So on and so forth. And obviously, this is the area we do lack the most data. First of all, think about it. The upfront study was a 12-month duration, but sort of arbitrary. And so we don't know. This is why the FLAIR trial is very interesting because, here you're doing an MRD adapted approach to therapy. And so there are some patients who extending the therapy might render them undetectable, and there are some patients who probably it doesn't matter. And so trying to parse out, who those patients might be, these are hopefully some of the studies we'll get to. And then, of course, the MRD testing keeps changing as well, right? So the platforms of testing are different amongst different institutions and depending on where you send them out and so on and so forth. And so we do need a lot more data for the majority of patients, obviously who want a time-limited approach based on the efficacy of some of these combinations. They're excellent, and so you're gonna wanna try to get patients off of therapy, but I do think we need a lot of work in that area so that we can figure out who are the patients we might extend those therapies? Did we shorten the therapy too prematurely in some of them and so on and so forth?
Great point you raised there, Nicole, about, we talked a lot about undetectable MRD, but it's very important you're looking at a paper nowadays, so you look at what was the methodology used to look at the MRD analysis. Was it 4-color flow, 6 or 8-color flow? Is it PCR-based? Is it NGS-based? And how the NGS is done, is it targeted NGS? So, and of course, those have very, very different limits of detection, and the really good papers kind of compare different methodologies and talk about the importance of what that is. But I think it's very incumbent on us to look at what's actually being looked at. I think there's a lot of questions about dosing and dose adjustments and dose modifications, but I've got a little good scenario here. David on the webcast has got a patient he's treated with ibrutinib, and the patient did well for 18 months, some side effects. He reduced the dose to 280. Did well for another 9 months, reduced the dose to 140, and that patient's now almost 2 years on that dose reduction dose. Patient's doing well, still in remission, side effects mostly subsided. Would you continue on the 140, increase to 280, increase to 420, or would you change at this point? I'm going to give you all a shot on this one. John.
Yeah, so I could be short or long here. I'm trying to figure out. But I would just continue on. The nice thing that ibrutinib has, particularly, is weight-based dosing, and we know exactly how much drug you need to inhibit BTK 90% of the time. And the other agents haven't really necessarily well defined that. I don't doubt that lower doses of other agents aren't going to have good coverage in very frail 80-year-old patients by any means. But we definitely know with ibrutinib, and it's about 2.5 mg per kg, gets really good coverage. And so I think I don't know all of the weight and the size of the patient, all these types of things, but clearly history is telling us that 2 years later there's no progression and likely there's good coverage there. So if there's tolerating it and doing well and has otherwise low risk features, and I would just keep doing what's going on with 140.
Yeah, pretty much the same. I think it's a missed opportunity, right? Because we're never going to go back and do those studies. I think it's important that, based on the PK data from a lot of the different covalent BTK inhibitors, we know what the target was to inhibit over 90%, BTK inhibition. What we don't know, or, we've talked about this but never did that study, was to look at, well, can then later on, after you've done that, can you then lower the dose of these individuals? Because we've already occupied and fully saturated BTK, and you may not need that dose anymore. And so that study will never get done, because I'm sure the companies aren't going to want to do that anymore. But the point is probably so. And so I think in this patient, if if they're otherwise doing well on reduced dosing, I would keep them. We talked about, I think John alluded to the fact that obviously if you have an intolerance, can you switch to a different BTK? Sure you can, but it sounds like this patient's already doing okay on reduced dosing, so I think that's fine.
And somebody who's been on ibrutinib for this long, it's highly likely there's going to be a new emerging adverse
Agreed.
event at this point.
Absolutely
Sorry, John,
agreed.
Also, I can just state, so Janssen, I think, has announced a study, the Taylor study, where they are looking at ibrutinib, venetoclax, and ibrutinib, and they're randomizing patients to continuing full dose or dose reducing it. So there are some studies doing it, and there have been other studies in the past that have looked at it, but that's probably going to be the most definitive answer. Does going to 280 diminish cardiovascular events, these kind of nuisance toxicities, and maintain efficacy, basically?
And obviously with Acala and Xano, you have the dosing, Acala is twice a day, Xano could be once or twice a day. So you can have one dose reduction with either of them, but that's it.
Yeah.
So.
Well, here's an interesting question. We had our case scenarios looking at kind of older patients with high-risk features. Okay, so you've got a young, fit patient with mutated immunoglobulin genes now needing therapy. How do you treat them?
Yeah, great point. So mutated IGHV, young, fit patient. This is where we see, long-term follow-up from FCR, really still several patients not progressing, really have that functional cure. I will say in the clinic, I have not been using FCR even in this setting, although I think there's data to support its use and could be part of the discussion and an option. Having said that, we see emerging data, the Gaia study looking at recently published, looking at the novel agents now really, whether it's doublet or triplet combinations, having excellent outcomes. And so I really would favor a novel agent-based approach. I think this is the patient population where a time-limited therapy, giving these patients a shot. So for standard of care in the US, that would be venetoclax, obinutuzumab per CLL14, or a clinical trial with a triplet combination or a doublet combination that's time-limited is important because you're not committing them to the cumulative toxicities, for example, of a covalent BTK inhibitor. But curious to know kind of the practice of others in this favorable risk subgroup.
Agreed. I definitely would offer its young, favorable patient population a time-limited approach unless they didn't want it. Other than that, I think that would be, give these folks a time off of therapy. They're going to do well long-term. They're easily salvageable. That's what I would favor on that individual.
Yeah.
Yeah, similarly.
Well, it's probably the person at the table who's given most FCR. I can't disagree more. I'm just completely reminded that the last patient I persuaded to have FCR who was young and was mutated and wanted ibrutinib, I convinced him to take FCR, and he tolerated it less well than anyone I've ever given FCR to my entire life, and reminds me every time I see him that be careful what you do. But you're absolutely right. We've got that data from the MD Anderson and now also from CLL8 of that group of patients in whom, if we can say anyone might be cured of their CLL, are that group of patients treated with FCR. We haven't got anything like that duration of therapy with of follow-up with the CLL14 cohort, obviously. But at the moment, that's the cohort that's sitting up there high still, and there's still a significant number of MRD negative patients, giving you the suggestion that you may well start to see the same kind of thing happening. It's the other groups of patients that are falling off on CLL14.
And we have Dr. Griever here, so we have to thank him for PCR as well.
Yeah. So, I'd certainly be having a conversation with the people about it, but I think most people would favor. And of course, the other thing to consider is not just the toxicities of my own patient, but the long-term follow-up in terms of things like risk of MDS. So there are other factors there, but it's a quite complicated conversation. John?
Yeah, and in CLL13, and I don't know if we'll see an updated, Dr. Ikor said on one of the initial presentations, had that subgroup of young less than 65 and IGHV mutated getting the Ven-based therapies versus FCR. FCR was doing very well,
Yeah.
but Ven-G and the triplets were doing just as well, if not better. And that, for me, really essential. Like, there's no role because you can get the fixed duration without that toxicity issue.
Well, we haven't got CAR T yet, but if you've got a patient you're taking to CAR T on a clinical trial, would pirtobrutinib or another non-covalent be your idea of a kind of, best bridging therapy towards CAR T?
That is a great question. We don't have too much data on even after pirtobrutinib, not even as a bridging strategy, but just thinking. There is some data out there that looks at patients getting CAR after discontinuing pirto for disease progression. There's data about ibrutinib combined with certain CD19 directed CAR T cell therapy. And there's some suggestion that maybe the ibrutinib profile could be better in terms of T cell mediation effects than a drug like pirtobrutinib. But I think it's a reasonable strategy if you have pirtobrutinib available and you need something to give while the cells are manufactured to give pirtobrutinib. I think now that it's available, it's a good option, but not a lot of data there.
Sure, John?
I was just going to say, the Transcend, IWCLL criteria, the CR rate's about 18%, I think it was. And those patients did well, but that's only 18%. Yeah. And when you look at epcoritamab, which is only 30 patients treated, but that CR rate per IWCLL is twice that. And so I do think that production of T cells plus the CLL T cell and whatever that production part of this issue that we have, I think could affect the quality there. And it's something that with bispecifics necessarily, it seems like maybe there's improved efficacy. We're still using that CLL T cell. So it's something that to weed out. But if I've got a bispecific or a CAR T, toxicity-wise, bispecifics are still winning there and logistics and all that kind of stuff. So I think plus, we've got degraders and all these small molecule inhibitors that we can keep kind of just going with these drugs. And so I think CAR T, I don't know. I've sent patients there. I think it's there. I would like it as a tool, right? But it's not benefiting a lot of patients, and there is toxicity.
It's sort of a little bit of an unfortunate story because CAR T keeps getting moved.
Yeah.
And not all of our older, frailer patients might be eligible for CAR T. So certainly have I bridged or younger patients with pirto? I have to CAR T. But John is alluding to the fact that there are multiple agents, and so it's becoming a little bit of a muddier, trickier playing field for sure.
And there is another great abstract. The question about Benda in CAR T, it rears its head where that causes problem. There is a lot of Benda use in CLL. It doesn't seem to be affecting in lymphoma, the Benda exposure with bispecifics, at least from the abstract that's being shown. So I'm looking forward to seeing that and kind of understanding that a little bit more because it's an area of interest and not well understood.
Because we've all seen the data on what ibrutinib does to T cell function, and we've seen the use, as you've alluded to, Megan, of using the ibrutinib with the CAR T. I'd love to see a lot more data on what the other BTK inhibitors do. I do not believe that ITK alone is the story of T cell function changes in CLL, and I think there's a lot of data emerging now that at least that acalabrutinib and zanubrutinib also have T cell modulatory effects. I haven't seen anything yet on pirtobrutinib, but I'm sure Lilly are supporting some studies looking at this. It'd be interesting to see. Certainly, when I've got a patient going to CAR T, I'm looking for an excuse to put them on ibrutinib, at least, even if they're already refractory, just in the hope that I'm going to be doing something. And I think the same thing's probably going to be true on bispecifics, because in the end, you still need effective T cells, which is the one thing that we know that CLL patients often don't have. It's quite surprising for T cells that aren't functional, how much CRS they can get quickly, though, isn't it? Yeah. Okay. Again, we talked a lot about MRD and its importance, and I guess its major importance is looking to be able to tell your patient they're MRD negative. What do we do more about if they're still positive? And how are you in your practice, John? Are you using MRD to kind of modulate what you're going to be thinking about doing?
So I don't know, I always feel bad about this question because I use it a lot and all the time, honestly, and I'm not living in a vacuum. I understand in most places, access and all these things are not available, but I find it very useful. I find its data, its information, its prognostic. But we are, learning, and I have seen, and I'm building experience and understanding kinetics of these clones, et cetera. And it does potentially influence the discussion that I have at that end of treatment if you're MRD positive, et cetera. So at least in the US and in our practice in New York City, obviously we don't see lots of reimbursement issues. And so I do use it. I'm typically using NGS and a clonoSEQ assay to do it. And we're learning CLL13. I think they show data that's not, the depth of remission is starting to matter and getting to the 10⁻⁶. And so what does that drive to MRD negativity mean into the future? And do we need to get everybody there? I do think it's very important if you're using a fixed duration to try to achieve it in any way, manner, shape, or form.
Yeah. I agree. It really applies to the venetoclax fixed duration regimens, but I think one thing that comes up is like, should you check it with a covalent BTK inhibitor monotherapy? And I think there's really limited use there, and so again, investigational, not standard of care, and I think it's almost regimen specific at this point. What it means, not only what assay are you using, what sensitivity, but also what regimen are you checking it on, and what's the data there.
I can say I do use it in BTK patients as well, and anecdotes, but I've caught non-compliance with it. I've seen the MRD rising, and it's a young patient. I'm like, are you really taking this? And they're like, yeah, you caught me. And then sure enough, they go back on and it's coming down. Not that that's a reason to do it, but it's information again, and you can potentially impact a progression. And I just caught a patient who was about 8 years on ibrutinib, and then MRD 3 years prior actually started to rise. The ALC was normal, but it went from 3 to 5 to 15%, and then he came in and the ALC was 15 and true progression. So you start to understand we don't modify necessarily what we're doing, but again, you're not shocked or surprised when something happens, and at least you can react quickly and with knowledge.
Well, that's controversial. Too.
I'd love to hear it, yeah.
No, in a good way, meaning, right, so for those patients that we do know who are on a covalent BTK inhibitor and do start having evidence of progressive disease, whether that be by you checking MRD, or there's some of those individuals who you could argue could still be monitored, right?
And
so
that's
3 years, a whole
yes.
other question,
Yes.
right? And then the question is, or do you wait, or do you switch their therapy sooner? And so I think that sequencing of therapies, whether you start one on the rise of MRD or versus true progression via IWCLL criteria is something that also we need to, adequately address. And part of that will be dependent, I think, also on regimen, because you might not want to wait until somebody gets so bulky that you have to worry about.
That's why I'm smiling.
Right? You're smiling?
I'm smiling because I sit on the IWCLL committee, and we're rewriting the guidelines right now, and we're arguing about this very issue. The IWCLL criteria are very clear about when you wait for progression, but do you really want to wait that long for a patient to progress that you're going to put on venetoclax and you're going to wait till they're high risk?
Till they're high risk.
Or might you get a better approach if you know you're going to treat them earlier? God, I'd probably get myself thrown off the committee for saying this publicly, but the big question is, why no other disease setting do we wait for the patient to become bulky before we treat them again? So in that setting, and particularly if I'm going to use a BCL2 inhibitor, I'm really probably not going to wait until
they're high risk. But there's some individuals who can go a really long time.
Yeah, totally.
Exactly.
And still have not high risk disease, and so that's
But I guess what the question is really alluding to
ultimately
is, are there those people in whom you would not think about retreatment, but how would you modify the treatment you're already on and not wait for a progression? And I guess we might all be tempted to do it, and we might do it, and sometimes we won't publicly admit to it, but the issue is it's probably a lack of evidence that would make us hesitate to say this is the right or not the right thing to do.
and ultimately, does that improve PFS and overall survival or their time to next? This is the questions we need to get at with data.
Sorry, a lot of these questions kind of cover the same sort of stuff. I'm trying to kind of pull them together because we're not going to have time to get through everything. What about that? Oh, sorry, yeah. One more, last question, okay. thinking of patients not progressing. So that patient who's very slow to respond, very persistent lymphocytosis after BTK inhibitor. John, let's start with you. I keep going to Megan all the time because she's on the far end for me.
Yeah, I mean, I think they always give us some concern. Sometimes we push these white counts up to 400,000. And in those types of patients, it can take 2 to 3 years to normalize it. But if you stick with it, I mean, it ratchets down every time they come in. It's really when you start to see it plateau. But these PRLs, haven't really necessarily shown that they have some inferior long-term outcome, and obviously with high-risk features, you might think about the patient differently. But I stay the course, and it comes down, and it can normalize, but it can take years. I know early data was like median about 9 months, which is kind of what the expectation is. But there are patients, especially when you push them really high, that take some time.
Well, thank you, Carmine, for the reminder. I was having so much fun, I completely hadn't noticed that we had run out of time. I'd like to thank all of you for being here. I'd like to remind you to please complete and submit your post-test and evaluation to get your credit, which is very important. To download the slides and practice the age, you can get it at peerview.com/2023-CLL. You can watch the replay of this event. Oh God, that sounds like my idea of torture, but no. In the next 24 hours, and then an online activity in the coming weeks. And of course, you can request live meetings at your institution. So all that remains for me is to be able to thank fabulous faculty we've had today. So thank you very much. Thank all of you. You must have enjoyed some of it, or you're just too heavy after your lunch to be able to stand up and leave the room. But you've all stayed with us, so that's been fantastic. So thank you very much, and enjoy the rest of the meeting. Thank you.